Oh, good evening and thanks for joining. I'm Chris Walker. It's my great pleasure to act as moderator during this webinar. And the webinar is on exploring orthopedic pre and post-operative challenges of edema management. Many thanks to Owen Mumford and First Kind Limited for sponsoring today's session. I just want to go over some quick house rules. The webinar will last around 1 hour and there will be a Q&A session after each speaker's presentation. This will last around 10 to 15 minutes. Due to the number of delegates we have on the webinar today, I ask that your questions are submitted via the chat button, and you can send these during the presentation. I will collate the questions during the presentation and ask these directly to the speaker at the end of their presentations. In the likelihood we're going to get more questions than we have time for, both speakers have kindly agreed to reply to any questions at a later stage, and we'll get back to you with their replies. Any specific questions relating directly to Gecko will follow up via our distribution partners in markets outside France, and in France they'll be followed up by Owen Mumford directly. So it's an honor to introduce this evening our first speaker, Dr. Jason Snibbe. Dr. Snibbe is a board certified orthopedic surgeon practicing in Beverly Hills, with fellowship training in sports medicine and joint replacement surgery. He performs surgery on the shoulder, elbow, hip and knee. His practice has a special focus on hip preservation and reconstructive surgery. He specializes in hip preservation techniques using advanced arthroscopic hip surgery. He also performs minimally invasive hip and knee replacements, which allow patients an accelerated recovery. Dr. Snibbe will talk about his experience using Gecko post-operatively to control edema following total knee and hip arthroplasty as part of a patient's recovery program. Over to you, Dr. Snibbe.
Thank you very much. I really appreciate it. It's really an honor to be on this panel and to give a talk today to everybody out there. I was crying at the beginning of the connection because I realized our friends in Bordeaux, France are there in one of my favorite places in the world to drink wine and eat. So I hopefully next time we have this meeting, we'll all be together in Bordeaux, France, having a nice glass of wine. But I thank you for having me. I just want to say that, you know, I was introduced to Gecko several years ago. I think it's now been, I think it may be 3 years, maybe a little bit longer. And to me, it's one of the most disruptive, most incredibly elegant technologies that I've ever come across in my career in orthopedics. And I've been in practice almost 20 years. It's such a simple device and it's so elegant and it's such a simple idea, but it really combats one of the most critical parts of what we do. And the key to outcomes and the key to having great result and minimize pain and improve function is to minimize edema. And I think edema is kind of the big elephant in the room that nobody really talks about. And we know that edema makes you get your range of motion faster. We know that minimizing edema makes your wounds heal better. We know by minimizing edema, you can get patients to the operating room quicker with traumatic cases, with fractures, with ankle sprains, stuff like that. So that's such a critical part. And, you know, most of the time it's elevation and ice. And then there's all these very, in my opinion, very archaic instruments, such as sequential devices and these TED hose, which are very difficult for a patient to get on and off. And really, in my opinion, really don't make a huge impact. And there's a lot of data proving that they really don't work. They really don't provide any significant improvement in venous return. So I think that you'll find this technology really, really fascinating. You'll find it very simple, which I think is the most important thing. It's easy. And there's so many different applications for it in all different markets. But today, obviously, we're talking about orthopedics. And I'm gonna jump into my my lecture right now on my PowerPoint here, so you guys can share with me. So here's can everybody see that? Yeah, everybody see that? So this is I'm just gonna talk about leg edema after total joint arthroplasty. And let's see if I can make this work. Good. So We know that post-operative edema can cause tissue injury, can accumulate fluid, and we know that swelling is part of the process. We know that, you know, when a person has a knee replacement, when they're 7 days, 10 days out, the swelling will be significant. And that's when people will call your office and say, hey, my leg is super swollen. It's 2 times, 3 times the size of the other knee. You know, what's going on? And this swelling can last for quite a while. And as you know, can limit range of motion. So there's this concept of these vicious circles of arthrogenic muscle inhibition that we talk about with edema. And we know that when you have a lot of edema in your leg, the swelling can cause limitations in movement and limitations in how the muscles perform. So the joint damage occurs from the surgery or from a traumatic injury. You get muscle wasting, you get muscle weakness because those muscles can't fire normally. And then you get this reflex inhibition that goes in a circle that causes weakness, continued swelling, muscle wasting. And this process is very important because to understand this is that how do we make this better? How do we make the functional status of the patient better? And how can we do that in a very elegant and accurate way? So like I said in the previous slide, about 6 to 8 days following surgeries when people have the most swelling. And you can see on this chart, you know, post-total knee, post-total hip, the swelling continues and the swelling gradually declines. Talk about is that how many phone calls do you get into your office to ask about swelling? How many people end up going to the emergency room because they think they have a DVT and all it is edema? And how many people have limited range of motion? How many people have problems getting the range of motion and suffer for months on down the line because they've lost so much muscle, they've had limited range of motion, and then ultimately they get a poor result because of the edema. So there's a lot of research about edema out there, about knee swelling and inflammation around a total knee that can impact your extension strength. And you can see in these changes that as the swelling goes down, your strength improves, your fast speed walking improves. There's also some studies about quadriceps strength, that as the swelling gets larger, your quadriceps strength gets less and less and less. And we know that from, you know, patients that have edema, patients that have ACL surgery, patients that have total knees, that they lose that muscle. And the problem is also that the part a lot of people don't talk about is that before the patient ever sees you, you know, Mrs. Smith has a bad knee, she needs a knee replacement. She ends up having a lot of weakness for the last 2 years because she can't use her knee normally. And then you do an operation on her and then her quads shut down because she's got so much edema. You really put that patient in a bad situation where they can really have a poor outcome. So this edema can cause loss of muscle strength, impaired recovery, and loss of independence. Like I said, hospital visits. Well, we never talk about, and a part that it's rarely discussed in the arthroplasty world is surgical revision. How many patients are we taking back because their wounds are draining, because they're having dehiscence of the wound, because there's so much tension on the wound? And how can we allow that wound? How can we improve the microvascular circulation of the leg? How can we improve wound healing? What we'll end up doing is decreasing healthcare utilization, but right now it's increasing healthcare utilization because of that edema. So a majority of these patients experience edema, 95%. I think that it's extremely rare for someone not to have edema after surgery. This accounts in America for almost 250,000 patients that go to the emergency room because their leg is swollen. They end up getting unnecessary ultrasounds. They sometimes get unnecessary admissions to the hospital. And this is an enormous economic burden, and we can lessen that. Here again is emergency visits for edema and pain. You can see these visits after total joint arthroplasty. So how do we solve this problem? The problem it can be solved by this very, very ingenious, elegant device. they take a thing that we've known for so many years is a nerve stimulator, right? A nerve stimulator like a TENS unit, like a nerve stimulator to stimulate the nerves to do nerve conduction testing. We know we can stimulate nerves, but what's so elegant about it is the peroneal nerve is so superficial on the lower leg. So by using the peroneal nerve and stimulating the peroneal nerve, we stimulate the deep muscles within the leg. All of that lateral compartment and anterior compartment of the lateral side of the leg, all those muscles fire when you fire that peroneal nerve. And some of those muscles are the very, very deep muscles within the leg. And guess what? When those muscles fire, those deep veins within the leg squeeze and return blood out of the extremity. So they're using a simple neuromuscular stimulation device to combat edema. And it's in this simple, elegant, it looks like a wristwatch that adheres to the lower leg. It has a battery within it. It's disposable and increases the circulation of the lower extremity. So instead of having a big, bulky SCD, instead of having to pull on this massive, tight TED hose on your leg, you have this beautiful little device that is so simple that you can wear under pants, you can walk around with it, you can sleep with it. We can put it on patients during surgery to improve venous return during surgery. So it really has such an application because it's so simple, it's so low profile, and it treats this simple problem. And so I think that you can see on the image on the right, you can see a patient wearing it after a total joint. I use a waterproof dressing on my patients for ACLs, for total knees. So you can put your waterproof dressing on and apply this. You can apply it underneath an ACE wrap. It's very simple. And you can see there's gel underneath it. There's the power source, and there's 24 hours of battery life. The way it works is you push the plus button, and those two lights, which are next to the plus and minus button, will flash, and that will flash telling you the level. And the levels go from 0 to, I believe, 11 right now. And so they go up, and then they stimulate your leg, and you'll feel a little twitch in your foot. The patient will feel a little twitch in your foot, and that's what you want them to have. And you can wear it walking around. I've actually worn them in the operating room when I work, and you put them on for 24 hours and you take it off and you throw it away and you put another one on. So it's very, very simple. So when you look at the geko-device and you look at walking, like how well, everybody knows that walking increases venous return and walking improves the circulation in your leg. And so when we compared walking with the geko-device, it's comparable to 60% of natural dorsiflexion in the leg. So you're getting basically 60% of a patient walking around, which is incredible. You know, it's really incredible. And it significantly increases the blood flow to the extremity. With laser Doppler fleximetry, we have a 25-fold increase in the laser Doppler flow of the leg. You can see that on the left, you see the image when it's off. On the right, you see when it's on, you see enormous amount of increased flow. And what's interesting is because you're increasing the venous return, you're also increasing the arterial flow to the leg, because as the venous return increases, arterial flow increases. So you can see that arterial, that red line there is the arterial flow. And guess what? That can improve wound healing. It can improve blood flow to wounds. It really helps the overall flow of blood in the extremity. And it exceeds the pump. And I think that it may be in this talk, but the geko-device increases venous return 30% better than a lower extremity SCD or a sequential device. And as you can see, the sequential device has to be plugged into a machine, and many people, some surgeons in America use these portable ones. The patients lose the tubing, the machine runs out of batteries, it's hard to carry it around, it's very bulky, you have to wear shorts all the time, you can't wear pants. It's a very difficult device. The gecko device, as you can see, is elegant, low profile, easy to put on any clothes that you wear. I mean, people can walk around with them all the time, and it's very simple. Here you can see the peak velocity of flow compared to SCD devices. You can see that the gecko is on the left, and the other device is on the right. You can see there's enormous, significantly increased blood flow with arterial and venous return. And then, you know, the other part we talked about is wound healing. So there's a significant improvement in microcirculation. That microcirculation, these are the tiny little blood vessels that are inside the skin. And so, you know, the gecko device has been used by many of the wound healing people around the country to improve wound healing in diabetic wounds, also in you know, lower extremity wounds, whether you're trying to heal things around a foot and ankle, where notoriously the blood flow in that area is poor. I've noticed in my own practice, I'm the largest user of the gecko device in the entire US, and my wounds have been phenomenal. I mean, when people come into the office, they always say to me, they're like, you know, I use that gecko device for, you know, 10, 12 days, and I feel like my wound is already healed. I just feel like it's so much better, and they just don't have the edema and the swelling in their legs. It's very rare for me to see a patient with significant swelling in their lower extremities. So I think that, and then I always tell my father is diabetic, and he had a cut on his foot, and he ended up having to have surgery to clean out a wound on the bottom of his foot. And I put a gecko on him for 2 weeks. We wore geckos for 2 weeks on his leg, and the wound healed perfectly. He has no problems. And all of the podiatrists, the wound specialists all said, we've never seen a wound heal like this. It's just absolutely incredible. And my father to this day says the thing that saved his leg was the gecko device. So you can see that blood flow volume, this is venous return, venous blood flow, as well as arterial blood flow. And the first bar is just baseline. The second bar is gecko, and the other ones are sequential devices. And you can see that the gecko statistically significantly increases the venous return and the arterial blood flow to the leg by 20 to 30%, which is very incredible given the fact it's such a simple device. And then here you can see some of the other studies, which again show that gecko far surpasses all the other devices that are on the market. Again, more increased blood flow and blood microcirculation and blood velocity. And so we look at lower extremity after total joint arthroplasty, and you know, the changes in the circumference of the leg is significant, you know? And so I think that when you talk about that vicious cycle that we talked about at the beginning of the lecture, that vicious cycle is definitely significant for muscle return to muscle control, return of strength and power in the leg. And again, it's better than compression stockings. I think that you can see that it's significantly better there to improve the comfort of the patient. So I think that, you know, this is a frustrating problem that doesn't get talked about. And I think there's an enormous amount of money and effort that goes into analyzing patients with lower extremity swelling. And I think that when you talk about post-surgical patients, this is the best, most advanced, simplest device that exists on the market that can combat the lower extremity edema problem. And I think that when you talk about outcomes in America, for those of you all over the world, we are moving all of our joint replacement to outpatient procedures. I'm doing 30, maybe 40% of my total knees and total hips and total shoulders all in a surgery center, and they're going home the same day. And so they're not sitting in a hospital bed with sequentials on and with TED hose. So I don't use TED hose at all. My patients get the gecko device placed on them within 30 minutes of the end of the surgery. So they go to the recovery room, a gecko device gets put on their leg immediately. And so they wear those for approximately 10 to 12 days, and they really improve their lower extremity swelling. essentially in my practice has eliminated the emergency room visits, has eliminated all the phone calls, and has really, in my opinion, improved the outcomes where patients are like, I feel amazing. I'm doing fantastic. My wound is healing great and my legs don't hurt. So I think that there's a real compelling, to conclude, I think that there's a really compelling device here. I think this device, I looked at it for the first time and I said, this is an incredible idea. It takes a simple technology and uses it in such an elegant way to eliminate pain, to improve function in your patients. And I tell many people that work in the company, I say, this is a device that just has enormous amount of potential. I say, like when I go on a transatlantic, when I fly to Europe, hopefully next year we'll be able to fly to Europe, but I wear gecko devices on my legs to decrease swelling. And so when I get up out of the plane after a 12-hour flight, my legs feel great. And you realize that there's an enormous amount of impact that this device can have, but why not make the outcomes of your patients, the outcomes of your surgeries improve in such a significant way? And it's all types of orthopedic patients, ankle sprains, foot fractures, just plain swelling in the knee, from a meniscus tear. It really can combat a lot of the problems that patients have with lower extremity edema. Thank you very much. I appreciate it.
Thank you, Dr. Snibbe, for a great presentation. We have got some questions that have come in from our participants on the webinar. The first one is what's your protocol for the use of gecko following total knee arthroplasty and total hip surgery?
So my protocol is that they get approximately 10 days of gecko. So they put the gecko on immediately. So they put it on either in the hospital or the surgery center. So it immediately, and I don't put it on both extremities. I just put it on the operative extremity. I have them turn it up to a level where their foot twitches slightly, and they wear it until the gecko device runs out. And so some patients can wear it when they sleep at night. So, and they don't mind it. And there's also some data to say if you turn it down, if you turn the gecko device down where the foot is not twitching, there's still a benefit. You're still getting some neurostimulation that improves venous return. So some patients don't like to wear it at night. So if you push the negative button for 3 seconds, it will turn off. And so they'll turn it off. So sometimes if they just wear it during the day, they'll be able to stretch it out for almost 2 weeks of use of gecko. So I use it for every single patient. It gets put on immediately after surgery.
Fantastic. And regarding you mentioned just within answering that question that you use it when the patient's discharged from yourself. What's your sort of recommendation for the length of time the patient wears it for a number of days, say following a total knee or a total hip arthroplasty?
Well, I think that you have to go out. I don't think you're going to get the benefit if you just wear it for 3 or 4 days, or maybe even 5 days. I think that everybody knows that 7 to 10 day mark is really, the prime time for swelling. And I think that if you wear it up to 10 days, what you'll see is that they will not get that surge of swelling that most people get after a total knee or a total hip. So I think 10 days is critical, and I think that will prevent that surge of swelling. I think that we have to, we're currently doing a lot of research on it right now here in the States, and I think that we're even going to probably look at, like, is there a benefit for them to wear it for a month? Like, is it better to have a longer time of wearing the device, in the future? So, but right now we do it for 10 days.
Great. I've just had another question in. Is the device rechargeable, or is it used once only for 24 hours?
Yeah. So right now it's only good for 24 hours, but there is some discussion within the company that maybe designing a rechargeable device may be helpful. I think one thing that I didn't talk about is complications. What is the problem with the device? What are the things that can go wrong? I think that a couple things, the few things that we've had issues with, which are very minimal. I mean, we're talking about 1 or 2 patients here. One is allergic reaction. Some people, when they put that adhesive on their leg, they get an allergic reaction. Some people actually, they get a little redness, but it doesn't really cause any pain or any problem, it just looks red. So that's all we really get. No one has really had like a bad reaction to it, just a little bit of redness. And that's, again, 1 or 2 patients out of hundreds. The other issue is that very, very thin women, their nerve is so close to the skin that when you put this on them, it stimulates their nerve so much that even at the lowest level, it's annoying. It's just their leg is like flying around. So some of the skinny women, it's a problem. And then also some people with high BMI, like obese patients, sometimes their leg is so big that when they put the gecko device, even at the highest level, it doesn't work. It doesn't stimulate the nerve. So sometimes there's some limitations to what you do. But in the majority of patients, I've had 0 problems. And I've had patients call me when they've had other surgeries, like spine surgeries that I don't do, spine surgeries, foot and ankle surgeries, saying, hey, doc, can you connect me with the guy that got me the gecko? I want to use that for my other surgery because I love the device.
Great. And another question that's just come in is can it be used for some nerve injuries like neuropraxia? Have you had any experience in that?
Yeah, I think that, yes, I think that I had a patient that was sent to me in second opinion who had a sciatic nerve injury, and we put the patient on Neurontin, gabapentin, and we put them on a gecko device for about 2 weeks. And there was the nerve significantly improved during that time. Again, I don't know if the nerve was going to get better anyway, but it significantly improved. And we've also, some of my spine colleagues have used it for some patients that have some nerve injury. And I think that it definitely, just like nerve stimulation, we know that the more you stimulate a nerve, the more you stimulate the body to send, so the nerve heals, the nerve continues to heal, and your body sends those healing messages throughout the nerve. So I think that definitely that is an application of this device.
Great. And the final question I have was, do you use compression bandaging following your knee arthroplasty, and how would you use that with the gecko device?
Yeah, so I use, what I do is I do a subcuticular closure. I don't put any, I don't use staples, and I put steri strips. I put what they call a Mepilex dressing. It's like a sterile dressing, but it's adhesive, so it's completely waterproof. And then I put an ACE wrap around the leg. But what we do is we put it so there's a little bit of room so that the nurse so the dressing is essentially waterproof and sealed underneath. And so we roll up the ACE wrap because it's already closed underneath, and we put the gecko on in the recovery room. And so they take that wrap off the next day. So the wrap is just for a little bit of compression.
Fantastic. And that's the main group of questions. There's a couple that will follow up individually with some of the delegates that are more device related. But many thanks, Dr. Snibby, for a great talk and for your Q&A session. Much appreciated. Well, thank you very much. So on to our next speaker. So it's my honor to introduce Mr. Paul Baker. Mr. Paul Baker is a consultant orthopedic surgeon at the South Tees Hospital at NHS Foundation Trust in the UK. He's the Director for Research and Innovation for the Trust and for NHS Foundation Trust, and an Executive Director of the Durham Tees Valley Research Alliance. He's an experienced researcher and grant holder with over 80 peer-reviewed papers. Mr. Baker will talk about his experience integrating the gecko device into his clinical practice. This follows his published study on the use of gecko in ORIF patients for preoperative edema, which led to reducing the time for these patients to be theatre ready versus standard of care. So over to you, Mr. Baker.
Yes, well, thank you, Chris, and thank you, the First Kind team and Mumford for inviting me to speak today. I'd just like to, first of all, just echo the sentiments of Dr. Snibby and his talk, and the real feeling that this is a very innovative device that has quite a wide range of applications, not only in edema reduction, but also in wound healing, improving vascular flow into the distal limb. You know, there are roles in pain modulation, as you touched on at the end of the talk there, DVT prevention as well. And really my interest in the Gecko came around about 4 or 5 years ago when the device was presented to me, and it was being presented really as a device for DVT reduction. And I spoke to the First Kind team, and we had a think around the other applications, and you know, really this idea of it being a real strong device for the treatment of edema and edema reduction was something that grew out of that, and that's been borne out now in a number of scientific publications and the clinical expert testimony of clinicians like Dr. Sneeby. So what I'll do is I'll just share my presentation. Okay, so hopefully everyone can see that. So this is a presentation looking at preoperative edema reduction in the trauma setting, and the context of this is around ankle fractures in the NHS in United Kingdom. So as we all know, ankle fractures present in a variety of different ways, in a variety of different configurations, some being unstable and requiring surgical fixation, and some being stable or being suitable for non-operative fixation. And we know that in the group of patients that require surgical fixation, they can develop preoperative hematoma and preoperative edema that can limit the ability to do early surgical intervention. Ideally, we'd all like to get to these cases early, before swelling develops, but unfortunately that's not the reality of things within the NHS and other healthcare systems, whereby we don't have the ability to flex up capacity in our surgical suites to meet demand, and capacity is capped, and we have to work within that framework. So what we often see is a situation whereby patients are admitted with lower limb fractures around the ankle, hindfoot, midfoot, with swelling, and then we have to try and reduce that swelling to get their level to swelling to a level, or edema to a level that would be acceptable for surgical intervention, to try and reduce the risks of complications and post-surgical problems. And we know that interventions that reduce swelling can have significant benefits to patients and healthcare providers. And in the UK alone, you know, we see that about 20,000 procedures a year are done, you know, with patients having fixation of ankle fractures within the NHS setting. We do have guidance on this. Certainly in the UK, the British Orthopaedic Association has been keen to produce guidance on the management of ankle fractures, and they do recommend early surgery, but as I've mentioned, that's often not the reality of what can be achieved within the confines of our healthcare system, and this may be reflected in other healthcare systems across Europe and internationally. We have competing interests, as everyone does on the trauma lists. We have different injuries that, you know, may be a higher clinical priority, or others that have attract tariff and other financial incentives to do them sooner. And we found that actually ankle fractures are slightly the poor relation in all of this, and often get left to the end of the trauma list, or, you know, don't get done on that day's trauma list, giving a chance for swelling and edema to present and persist. And with what's important within these guidelines is there's no guidance on how to manage swelling and when edema may be at a safe level to permit surgery. So this is really at the whim of each individual clinician. This is data from the Health Episode Statistics Database, which is a national database within the UK, and it plots the national length of stay for ankle fractures. And what we see is that there's this target group with a prolonged length of stay, some of this due to persistent preoperative edema and the requirement for elevation and treatment of edema in the preoperative phase, but also for elevation and edema in the postoperative phase that can also limit recovery, rehabilitation, and the ability to mobilize post-surgery. And this is the group that we really need to target. So in the UK, our standard of care is that, you know, if a patient is admitted with an unstable ankle fracture, the ankle is reduced and placed into a temporary plaster back slab. Check X-ray is performed to ensure adequate reduction. And then we have a situation where the patient is ordinarily admitted to the trauma ward with a plan for surgical intervention. But what can happen in that intervening period prior to them getting to their slot-in surgery is that they can develop edema, and this can then delay their surgery. The options open to us here are that we just leave them in a plaster cast alone and elevate the limb, wait for gravity and swelling to naturally resolve. We supplement that with application of a pneumatic compression device, such as the one seen at the bottom there. And these are similar to the ones that Dr. Sneeby showed that are attached to pneumatic devices. It requires removal of the back slab, application of the device, which can be painful and uncomfortable in an unstable ankle fracture. If you need to reapply the plaster, that can also be quite logistically challenging, once the patient's hit the trauma ward. Patients don't like these, they're noisy, it ties the patient to the bed. The patients that share the bay with the patients don't like these pneumatic devices because they're noisy and they keep them awake at night. And then the third option is to put the patient in a spanning X-fix if we feel that the swelling is such significant enough that the surgery may be significantly delayed. Now, we did some background work on this, and this is what kind of drove my interest in this area, is that what we know is that when we look at patient experience and satisfaction following the surgical management of ankle fractures, one of the key determinants is delays to surgery and patient length of stay. And patients staying more than 3 or 4 days had a significantly poorer experience of their hospital episode than patients that got early surgery or surgery within the first 48 to 72 hours. So really we need to focus efforts on reducing that delay to surgery, and that really is focused around effective edema management. We know that foot pumps can be effective in the management of ankle fractures, but they're difficult to apply. They're a very inelegant device, logistically difficult to manage. Patients actually don't like them. And as Dr. Sneeby said, why would you want to use these devices when we have something as elegant and as straightforward as the Gecko? So we worked with First Kind and developed this research question. And we wanted to know, in patients admitted to hospital with an ankle fracture, does the application of the geko-device at the time of admission help to reduce time to theatre when compared to current standard of care? And we were interested in looking at this in a research setting because I had reservations that this would work, not because I doubted the device, but I doubted that patients would tolerate this when they had a broken ankle. And my concerns were quickly assuaded by the study and seeing patients with the device on, as they had a sort of an excellent experience of the device, and as we'll come to see, it proved its weight in gold in this setting in terms of edema reduction. So we designed this as a case control study. We identified 20 patients that were acutely admitted to the trauma ward with an ankle fracture, aged between 18 and 60. There were some exclusions, but nothing that would really limit the generalizability of the findings of this study. Prospective recruitment over a period of around about 6 months. What was interesting is when we approached patients for this, we had very few decline inclusion in the study, and they all seemed very interested and very keen to be involved. So this was not a difficult sell for patients to have on in this setting. And then our control group was a retrospective matched group where we matched them based on a variety of factors that I'll come to a bit later on. Similar to what Dr. Sneeby had shown, the device was applied over the comparoneal nerve around the fibular head. This works very well with the plaster cast or the back slab. We managed to train our plaster applicators in ED to make sure that the fibular head was accessible in this patient group. And if it's not in a plaster back slab, it's quite easy just to trim the plaster down on the ward and then apply this. And we would put the device on, turn it up to the setting that brought about a flicker of activity in the toe and foot, indicating that it was stimulating the nerve effectively. And what was interesting was that in all patients, we managed to get a response, and also that all of them tolerated it extremely well. We then matched the patients that we prospectively recruited into a historical cohort for comparison, and these were matched based on factors including whether the ankle was dislocated at presentation, the type of fracture and the configuration of the fracture fragments, gender and age. So we were able to create a well-matched group of patients. We did have some withdrawals from the study. One was because the surgeon treating them decided to treat the patient conservatively in the end after they'd already been recruited, and a few because they ended up having a spanning X-fix within 48 hours because the surgeon didn't have the equipoise to persist with the geko-device, and as it was a new device to their practice, wanted to put them in a spanning X-fix. So the key results of this were that when we looked at readiness for theatre and edema reduction, and this was judged on the consultant's assessment of when the patient was ready for theatre, and this was a group of consultants working in a major trauma centre in the UK with a significant experience of treating these fractures, was that the gecko had people ready to for theatre 2 days quicker than just leaving them in a back slab with elevation alone. We had 60% of people ready for theatre in 2 days compared to just over a quarter in the control group, and that was a 122% improvement over our standard of care. And these results, unsurprisingly, were statistically significant given the size effect that we noticed and the improvement in edema reduction with the geko-device. As I mentioned, it was well tolerated and it was easy to use. It was easy for the staff to apply. We left them on the patients 24 hours a day. We didn't turn them off at night, although we did permit the patients to turn them down to a level where they couldn't feel the flicker. And as Dr. Sneeby said, I think, you know, even when the device was at a what might be termed a subtherapeutic level and we weren't seeing a flicker in their foot, I still think it was having an effect on the patient and improving that venous return and arterial inflow into the leg and helping with edema reduction. When we looked at the finances behind this, Gecko was clearly cost saving, you know, based on the cost of a pair of Gecko devices in the packet. We could then use that packet for 48 hours worth of care, and given that 60% of our patients were ready for theatre within 48 hours, you know, this was a very moderate cost against the bed days of the patient waiting in hospital prior to surgery. You know, in this study, we did look at just inpatients, but there's no reason that this cannot be extrapolated to the outpatient setting in the same way that Dr. Sneeby has done with his knee replacement patients, where we apply the device in the ED at the point that the patient has had their back slab applied and adequate fracture reduction achieved, and then send them away with devices to wear sequentially for 48, 72 hours. We can bring them then back to the ward or the clinic setting with confidence that the edema should be reduced to a level to permit surgical intervention at that time. So the reality of the situation in the UK anyway is that the majority of patients, due to various comorbidities, frailties or home circumstances, are unable to go home and have to be admitted to hospital, and they block beds, and that can then have an impact because of the nature of the NHS on elective surgery and the throughput of elective patients. Unfortunately, we do not have separate trauma and elective hospitals for the majority of the NHS, and these people all share the same hospital footprint. The Gecko enabled us to get patients ready for theatre sooner. And then once they were ready, they remained ready, and it allowed us then for more precise theatre scheduling and for surgery to be performed at a time that was right for the patient, bearing in mind the other pressures on the service. And then we've extended this subsequently. We use this regularly now for all our lower limb fractures, basically anything from the distal tibia distally, so pilon fractures, ankle fractures, calcaneum, Lisfranc. And we've also used it in a number of tibial plateau fracture patients and noticed almost overnight some of the edema going out of the patient's legs, getting them ready for theatre when previously they may be waiting 2, 3, 5, 7 days for swelling and blistering to settle. This is settling at a much faster rate when we apply the Gecko device. And we also have had some experience mirroring Dr. Sneeby and using it in knee replacement patients with a very similar protocol and similar wound closure and dressings, and it seems to work very effectively in this patient group as well. What I'd also say is that when you use it preoperatively, this then helps with the management of the tissues intraoperatively and post-operatively, and can help with accelerated rehabilitation beginning sooner as the patient is more comfortable, they've had that edema resolve, and they don't seem to then generate as much edema in that perioperative, post-operative period either. So it seems to have a knock-on effect treating them prior to surgery on their post-operative trajectory as well. So, you know, for me as a researcher, you know, we've done quite a lot of work on this. I think we understand that this is a really phenomenal intervention. It works in a variety of settings, you know, not only the ankle fractures, but trauma more generally in the lower limb. We understand the populations that we might use it in and the comparators, but, you know, there's still some issues, particularly around lower limb trauma, about how we quantify edema. It's very difficult to quantify edema effectively when you've got a patient in a back slab. So we're doing now some further work using subepidermal moisture probes and bioimpedance devices, looking at how we can quantify that and get even more evidence of the benefits of the geko-device in that preoperative period to help with edema reduction. And that'll be kind of where we're going over the next 12 to 18 months. So that's all I have for the time being. If anyone has any questions, I'll be happy to take them.
Okay, bear with me a second. Let me just start the video on. There we go. Well, thank you, Mr. Baker, for an excellent presentation. We have got some questions from the participants. So one of the questions was, do your patients wear the gecko post-surgery? So once they've had the ORIF procedure, do they continue to wear the gecko once they're cast and ready to leave?
Yes. So we you know, our patient, what's interesting and what I didn't mention is that we found that the patients that had it prior to surgery seem to have anecdotally a reduction in their requirement for analgesia. I think there is an analgesic effect of this, you know, a bit like a TENS machine in the way it does, you know, for women in labor. So what we notice is that they become quite attached to their devices, and then after surgery they want to persist with them. So we do send them home with them, but unfortunately we only give them 48 hours worth of supply, and that's usually that's an issue of a finance within the NHS rather than anything else, of me having to make a business case if I give them, you know, a month's worth after surgery, you know, because we don't have you know that evidence afterwards. What we do know is that, you know, the patients like them and they do ask for them after surgery, and we do persist with them for a short period after their you know, when they go home.
Great. I've had another question that's just come through was, can it be used for upper limb trauma as a device, in your opinion?
I think that's challenging. You know, quite where you would put it on the upper limb, I think is difficult to understand. You know, if you're talking about upper limb trauma and swelling around the wrist and hand, you know, would you put that over the you know, radial nerve, ulnar nerve, you know, the posterior interosseous? It's difficult to know where would be the best place to do that for edema reduction and swelling reduction. I think the other advantage with the upper limb that you don't have in the lower limb is it's much easier to elevate, and you can elevate that more effectively, and the effects of gravity are you know, easier to harness with the upper limb, because if you put the arm in a broad arm sling or in a Bradford sling to elevate the limb, it's slightly more challenging with the lower limb, which tends to spend a lot more time dependent. So you know, I think, you know, while in theory you could, I'm not entirely sure in my own mind what the best strategy would be to achieve that. Thank you
for that. And another question that's come in is can you use the gecko with, you mentioned X-fix devices within your study, that was an exclusion. Have you had any experience using the gecko with an X-fix device on? Yeah, we did actually. We you know, we regularly put them on if patients do have an X-fix, we supplement that with a gecko as well. I think what we found is that actually the gecko tends to work better if the patient's got a back slab on rather than an X-fix. I'm not entirely certain as to why that is. I think there's something to do with the foot pumping against the confines of the back slab that
gives a synergistic effect as well. But yeah, you can easily put them on while the patient's in an X-fix as well, and that goes for spanning X-fixes over the ankle or a spanning X-fix across the knee in the case of intra-articular knee trauma as well.
Thank you. And finally was a question just come in. Is how long does it take to fit a gecko to a patient from a staff perspective?
From a staff perspective, 2 minutes. I mean, being realistic here, you go along, the landmarks are usually easy to palpate, unless you've got a very morbidly obese patient. The device is then just taken out the packet and the sticky strips removed and then applied directly over. And there's a line that guides you relative to where the fibula head is. Sometimes there's a little bit of fiddling just to find the right setting and just to find the right position, but really with 60 seconds, 2 minutes worth of fitting, you can bring about that flickering response in the toe and the foot that indicates that it's stimulating the peroneal nerve.
That's great. And another question that came in is in terms of integrating it into your care pathway, has that been easy to do with regards to training the staff and using the device?
Yeah, I mean, it was when we first used the device, we needed a bit of training. The trauma ward is a busy place. Staff work on shifts, so we put on a bit of training with the help of the First Kind team to train the staff, and then once we trained everybody and the senior team were trained, the nurses in charge, the nurse managers, and the senior staff nurses, they were able to then cascade train that to all new people rotating into the department. And so we've not had the need for any additional training. Once we did that first batch of training, they've been able to then sort of, do peer-to-peer training as new people have rotated in. I think that's one of the beauties of this, is that it is easy to apply, it's easy to use, and it's very intuitive in how it works. As long as they understand the anatomy and can press the plus button to turn it on, it's pretty foolproof. There's not a lot that can go wrong. They just need to make sure that they are getting that response in the foot, and then the patients will improve from there.
Great. From the panelists, there's a few questions which we'll pick up later, which are more device related. So I'll bring it to a close. Many thanks to Mr. Baker for his presentation and taking the Q&A, and also to Dr. Snibby for their participation in the webinar this evening. I wish you all a good evening, and we'll follow up with any of the other questions. The session's been recorded, so you'll have an access link to that at a later stage. So many thanks, and goodbye from me.
Thank you.
Thank you very much.